Good evening, sir.
Good evening.
Good evening, all. We'll wait for 5 minutes and we'll start at 7:05 p.m.
Okay, sir.
Good
People are
evening, all.
joining. We'll just wait another 5 minutes only. मॅडम तोपर्यंत स्लाइड्स हे चेक करून घ्या ना.
बघितले सर, सगळ्यांनी केले.
सगळ्यांनी केले का?
हो हो हो.
ओके ओके, थँक्यू.
आणि
मी जरा
सगळे जॉईन
उशिरा
झाले.
जॉईन झालोय. माझा
चेअरपर्सन
अजून
माझा आवाज येतोय का?
हा येतोय.
सर, फॅकल्टी एमएमसी ऑब्झर्वर चेअरपर्सन सगळे जॉईन झाले.
ओके.
सध्या 70 लोक आहेत. हॅलो.
येस शीतल मॅम,
सुरू कर. हो हो सर,
वी
सुरू
विल
करू.
स्टार्ट.
ओके
येस.
सर. Respected Honorable President Dr. Avinash Bhosle sir, Vice President Dr. Vikas Karne sir, President-elect Dr. Ragesh Chagrapalli sir, then Treasurer Dr. Sachin Chandolkar, Newsletter Editor SAMS Dr. Shilpa Tivaskar, today's esteemed invited chairperson Dr. Lalit Kumar Raigar sir and Dr. Sanjita Umbarkar madam, then today's esteemed faculty Dr. Amol Kodalkar sir, Dr. Ajita Annachatri and Dr. Samrat Naik, and today's MMC observer Dr. Jayashree Kenkre madam, past office bearers of SAMS, all national GCs, SAMS advisory, GC members of SAMS, president and secretary of various city branches. A very good evening to all of you. Welcome to this SAMS Colloquium, which is organized by SAMS in association with the Borivali branch. I really thanks to Dr. Rajesh Rao sir and Borivali branch for supporting for MMC credit hours today. असतो मा सद्गमय तमसो मा ज्योतिर्गमय.
Okay.
सर
Thank
सर
you,
माझंही समोर
Sheetal
घ्या.
ma'am.
ठीक. Taking blessings of Saraswati, we are starting today's activity. So to begin, I request President Dr. Avinash Bhosle sir to deliver his presidential address.
Yes, thank you. Good evening, everyone. I welcome you all to today's first MMC accredited SAMS webinar. And I welcome Dr. Jayasri Kenkre ma'am as a MMC observer. We will try to give you at least 10 MMC points through our webinar as I committed and promised when I took charge as president of SAMS. First and foremost, I extend my heartfelt congratulations to all the awardees and branches on receiving the prestigious ISA National Award this year. Maharashtra State has received a total of 54 awards, and it's a proud and pleasant moment for all of us to celebrate this grand success. These awards belong to each and every member of SAMS. And to those who didn't make it this time, don't be disheartened. You can try again next year. I am confident that with persistence and dedication, you will grab it next time. Today's topic is very common but complex and challenging. Intraoperative cardiac issues like hypertension, arrhythmias, and myocardial infarction require vigilance, early diagnosis, and multidisciplinary approach, as well as a balancing act also. As you know, it is the third common cause of intraoperative mortality. Detecting and treating instability early plays a crucial role in ensuring a safe outcome for surgical patient, especially in non-cardiac patient and especially if you are not a cardiac anesthesiologist. Our distinguished speakers will share their expertise on navigating these high pressure situation and our chairperson will offer valuable insight that will enhance your skills as an anesthesiologist. So let us hear and discuss their expertise. Thank you. Thank you very much. Over
Thank
to
you, sir.
Shital.
Now I request Dr. Vikas Karne sir to please introduce our chairperson, Dr. Lalit Kumar Rai.
Good evening and namaskar to all. It is my pleasure to introduce our first chairperson for today's webinar, Dr. Lalit Kumar Raigar. He is a senior professor, R&T Medical College, Udaipur. He is very active academically. He has 70 plus paper publications. He has been author to 2 books. He is a founder member of Association of Obstetric Anesthesia and has been vice president. He is elected as president-elect of Association of Obstetric Anesthesia. He's an ex-president of ISA Udaipur branch. He is a president. He was a president of ISA West Zone in 2020-23. He has organized various conferences, including RSCP Con 1998, Rajasthan ISA Con in 2006, AOA National Update in 2007, Rajasthan ISA Con, and Visa Con in 2013 when he was the organizing secretary. He has delivered Ways on Oration in 2018 in Shirdi. He has multiple awards and recognitions for him. He has been faculty for national and state conferences. He is also an external examiner for MD and DNB exams. And he has also been reviewer for LCS journals, IJA, Journal of Clinical Anesthesia, and also Epicare Journal. He will expertly guide today's discussion and on intraoperative cardiac juggling in non-cardiac surgery, and definitely will facilitate a productive exchange of ideas related to the topics. Let's welcome him for the today's webinar as a chairperson. Welcome, sir, Dr. Lalit Kumar.
Thank you,
Welcome,
Vikas
sir.
sir. Thank you very much for nice introduction.
Now I request
Yes.
Dr. Avinash Bhosle sir to introduce
Yes,
the
our
other chairperson.
another today's chairperson is Dr. Sanjita Umbarkar. I am very happy and I am proud also to share that she is my classmate since first year of MBBS, and in MD anesthesia we were at Solapur. So since I am we are together for almost 8.5 years. So she is now professor and HOD of cardiac anesthesia at St. GS Medical College and KM Hospital, Mumbai. She is president of ACTA Mumbai Executive Committee member of Indian College of Cardiac Anesthesia, member of Research Society, GSMC Mumbai, fellowship in TE, FICA, ECMO board certification, and she has 40 publication. Her area of interest is heart transplant and ECMO. So welcome, madam, for this
Yeah,
webinar.
thank you for that kind introduction.
Okay,
Thanks.
thank
Thank you,
you.
sir. Now we will start our webinar today. The first topic is arrhythmia. So the speaker for the first topic is Dr. Ajita Annachatre. मूर्ती छोटी पण कीर्तिमान म्हणतात ना, असंच आहे अजिताच. सो शी इज अ DMP anesthesiology and she has special fellow in cardiac anesthesiology by Indian Association Cardiac Anesthesiologists. Then she is the member of infective committee member, reviewer of IJA, even International Journal of Cardiac Anesthesia. She is a reviewer of National Journal of Cardiac Anesthesia and IJA. At present, she is working as associate professor in the Department of Anesthesiology, MGM Medical College, Sambhajinagar. Now, she has numerous award achievements and award in her pocket. She has received the Icon in Cardiac Anesthesia Award at World Census on Women Heart Failure, then Best Public Awareness State Award in 2024, President Appreciation Award State in 2021, Best Public Awareness National Award at Ahmedabad 2021. She has Appreciation Award by MGM Medical College in 2019. She has also received an Evan Award for Excellence in Educational Initiative at Ganga Hospital, Coimbatore. Then she has bestowed with the National Award Based Social Awareness at ISACON 2018 at Agra and 2017 at Kolkata, and also at Shirdi State Award for the Best Social Awareness. So now I welcome Dr. Ajita Annachatre Madam to deliver her lecture.
Thank you, madam, for my kind introduction. Good evening to all the office bearers of SAMS, and with the permission of respected moderators, today I will start my topic. My slides are visible, madam?
Yes.
Yeah, make it slideshow. Yes.
Thank you. My today's topic is intraoperative arrhythmia. It's a very vast topic, and the time allotted is just 20 minutes, but I have tried to cover all the important points. So the rhythm is basis of our life. If there is rhythm, harmony, we can share happiness, and once it disturbs, we can't share our happiness. So as in the heart also. The there are no conflict of interest in my presentation. The aims of today's presentation to discuss the perioperative causes of arrhythmias, how to identify the common arrhythmias, and common treatment options for the arrhythmias. As an anesthesiologist, we should know arrhythmias because the incidence of arrhythmias in intraoperative period in non-cardiac surgery as well as cardiac surgeries is pretty high. Right from the PSVT is 2.5% to the atrial premature beats 10%, junctional rhythm most common is 20%, ventricular PVC is 15%, and atrial fibrillation, it has a major contribution in the intraoperative period, that is up to 30% in non-cardiac surgeries, and it can go up to 90% in cardiac surgeries. So every anesthesiologist should immediately diagnose any ECG changes regarding the arrhythmias. The anesthesiologist should be able to intervene and give a proper treatment for the safe outcome of the patient. So as an anesthesiologist, I should anticipate which patients will throw arrhythmias intraoperatively. Not every patient throws the arrhythmias. So the patient factors are, as of course, the patients with pre-existing cardiac diseases, history of arrhythmia on regular treatment are prone to develop the arrhythmias. But now the new population of adult grown-up congenital heart diseases coming for the non-cardiac surgeries, and the patients with prosthetic valve implanted patients coming for the non-cardiac surgery, a new spectrum, and they have a high chances and susceptibility for the intraoperative arrhythmias. Other diseases like intracranial diseases, COPD, renal diseases are common causes to develop arrhythmias. As age increases, the atrial fibrillation is very common in intraoperative as well as postoperative period. Anesthesia factors. We anesthesiologists know right from the tracheal intubation, we use the drugs like succinylcholine, we do laryngoscopy, which has obnoxious effects and causes arrhythmias. General anesthetics like inhalational halothane is known for developing the arrhythmias like junctional tachycardias. Some inhalational anesthetics like sleofluorine can cause QTC interval prolongation at times. Same as for the extubation, there are arrhythmias. Reversal agents like neostigmine can cause QTC interval changes and have arrhythmias. We routinely give antiemetics, but there are many antiemetics, they can cause the QTC interval prolongation. Even at given local anesthesia, there can be vasovagal, or giving regional anesthesia like spinal anesthesia, epidural anesthesia, there can be arrhythmias. Interscalene blocks are known to have arrhythmias while the conduct of these regional blocks. Long surgeries, large fluid shifts, bleeding, causing acidosis and abnormality in the arterial blood gases, electrolyte imbalances like hypokalemia or hyperkalemia can induce intraoperative arrhythmias. When we conduct the procedures like central venous cannulation and PA catheter insertion, there are high chances of developing arrhythmias. There are some specific surgeries which have high incidence of arrhythmias. Yes, cardiac surgery, it is known, but the non-cardiac surgeries like thoracic, dental, carotid artery surgeries and GI surgeries with laparoscopic surgeries are prone to develop the arrhythmias. After knowing the causative factors which are susceptible to develop the intraoperative arrhythmia, we should have a brief idea about the conduction of the cardiac impulses. Yes, SA node is pacemaker. After producing the impulse, it get conducted through the internodal tract to the AV node, from AV node to the bundle of His, from bundle of His to the Purkinje to the left and right bundles, and then Purkinje fibers to every ventricular muscle, and the action potential generates. This action potential and the waveforms are we can interpret at the ECG. ECG is the confirmatory diagnostic modality for the diagnosis or knowing the type of arrhythmias, because it gives us the morphology of the all waves as well as the intervals of the conduction pathway. Cardiac cycle is depend on the syncytial activity of the heart and synchronicity of the cardiac conduction. Each atrial contraction is followed by the ventricular contraction, and then there is production of cardiac output. Why I am insisting? Because atrial kick or atrial contraction, it contribute up to 25% of our cardiac output at rest, and it can extend up to 40% in the exercise. There are some structural heart diseases where the cardiac output is more dependent on the atrial kick, and it can contribute up to 70 to 75%. So any disturbances or any absence of P wave or atrial contraction in such patient in intraoperative period can be disastrous. A brief idea of the action potential of the myocardium. We know there are 4 phases of the action potential, and these all phases are because of the ionic influx and efflux of the sodium, potassium, calcium channels. Why we should have idea of these action potential? Because our antiarrhythmic drugs, they are classified and they have action on these phases of the action potential of the heart muscle. There are 4 classes. First is sodium channel blocker, lidocaine, which we use intraoperatively, which we can use IV. Quinidine, procainamide, these are used orally in these arrhythmic patients to control the rhythm and heart rate. Beta adrenergic blockade drugs, yes, we also use it very commonly. That is esmolol, metoprolol. Potassium channel blockade, amiodarone. Amiodarone is a drug. It not only drug, it is severe, because all type of arrhythmias can be abolished with the help of injection amiodarone. So the dose, it is 300 milligram or 20 to 30 minutes, followed by 900 milligram over 24 hours infusion to control the rhythm and rate as well. The target of our patient's heart rate to control rhythm, it is 90 to 110 per minute. So after knowing the conduction of the heart, now In preoperative evaluation, when we see the patient, either patients are known cardiac disease patient, known arrhythmic patients on treatment, or sometimes we reveal that patient is having some problems regarding the conduction. After taking a detailed history of palpitation or either syncope or chest pain, if we see the ECG, we can make out that some ECG problems, rhythm problems are there. So we can evaluate these patients in detail with 2D echocardiography. 2D echocardiography will tell us about the ventricular function. If they are having arrhythmias, they may have thrombus in the LA. Chest X-ray will also give us about the idea of the lungs and heart. Electrolytes are very important because these patients, they are on multi-drugs and diuretics mainly. They causes the electrolyte disturbances like hypokalemia, which is the commonest cause of arrhythmia, intraoperative arrhythmias. The patient who are known of AF, they are always on anticoagulants. So we should know about the INR of the patient, and need of the bridging therapy is also planned in preoperative period. Risk assessment is also important. Depending on the patient cardiac index score, revised cardiac index score, we can explain risk of the procedure to the relatives as well as to the consultant surgeon about the patient's condition. CHAD score and Hasbleed score are applicable for the atrial fibrillation patients, which will give about the idea whether post-operatively this patient will have stroke or intraoperatively they will bleed more or not. Cardiologist consultation for controlling rate or rhythm in preoperative period is mandatory in elective surgery. If required, cardiologist can give definitive treatment like cardioversion, or they, in case of bradyarrhythmia, they can implant a permanent pacemaker or AICD implantation before the elective surgery. So arrhythmia needs a multidisciplinary approach prior posting the such patients for the non-cardiac surgeries. So we have anticipated that these patients could throw arrhythmias, then we should ready to fight in the form of our well-equipped preparation of the OT. There should be working defibrillator in OT with external defibrillator paddles also, as well as the external pacing pads also. Emergency medications like beta blockers, calcium channel blockers, amiodarone and digoxin should be present in our table. Depending on the type of surgery and patient factors, we can decide about the invasive monitoring, and if required, pacing cables and pacing box should be ready, and standby cardiologist to help in crisis is always good. So how to coming to the how to identify the common arrhythmias, sinus rhythm to arrhythmias. So this is a normal ECG. For sinus rhythm on ECG, there should be two requisites. One, the presence of P wave before each QRS complex with regular PR interval, and P wave should be upright in lead 2 and negative deflection in AVR. So in short, sinus rhythm is the result of normal cardiac electrical conduction with normal shapes of the waves, normal duration of intervals, and rate in between it's 60 to 100 per minute. So any deviation from the impulse formation or conduction pathway or rate can be labeled as arrhythmia. So what are the arrhythmias? The classification of arrhythmias depending on the heart rate. If the heart rate is less than 60, we call it as bradycardia, sinus bradycardia, or types of heart blocks. Tachycardia, narrow complex and wide complex tachycardias, atrial flutter, sinus tachycardia, supraventricular tachycardias, and broad complex QRS complexes are ventricular tachycardias and ventricular fibrillation. So coming to bradyarrhythmias, sinus bradycardia, when the heart rate less than 60 beats per minute, it is called sinus bradycardia. Sinus bradycardia can be present normally in the people in high vagal tone like athletics, or in old age patient because of the degeneration of the tract, there can be sinus bradycardia. The pathological conditions like acute myocardial ischemia, hypothermia, or intraoperatively hypothermia, hypothyroidism, or patients with cholestatic jaundice, raised ICT, they can show the sinus bradycardia. The treatment is depend on the symptoms. asymptomatic patients with sinus bradycardia, there is no need of giving any treatment intraoperatively. But if the patient collapses, there is decrease in blood pressure and signs of low perfusion, the drug of choice is atropine, atropine, and atropine. The dose is 0.5 to 1 mg IV stat. We can repeat it every 1 to 2 minutes up to the maximum of 3 mg. If the patient is not responding to atropine, you can try for the injection isoprenaline IV 5 to 10 microgram bolus with the infusion rate of 2 to 10 mics per minute. The other types of heart blocks are first degree heart block. The ECG mimics like a normal sinus rhythm, but if you carefully see, there is the PR interval, it is prolonged PR interval and it is more than 0.2 seconds. Generally, these patients, they do well, but they can land up into advanced degree of heart block and they may have a cardiovascular collapse. So vigilant monitoring is needed. Otherwise, there is no need of any treatment. Second degree heart block, also called as type 1 Wenckebach phenomena. The rate is variable. P waves are normal with constant PP interval. QRS are also narrow complexes, but the PR interval is progressively enlarged or progressively longer until one P wave is blocked. That means one P wave not followed by the QRS complexes, and again the same cycle is continued. So rhythm comes irregular if we check the pulse. Second degree AV block type 1, it is because above the AV node or above the bundle of His. Treatment is usually not indicated as this rhythm usually produces no symptoms, but vigilant monitoring is necessary. Second degree, that is Mobitz type 2 block. The rate is variable. P waves are in normal contour and the PP interval is constant, but QRS sometimes widened or sometimes narrow complexes. Conduction, their PR interval may be normal or prolonged, but it is continued. One P wave is not conducted to the ventricle and again the cycle repeats. This Mobitz type 2 can convert into the complete heart block, and that's why vigilant monitoring and pre-operative treatment is mandatory. We should keep ready artificial pacing inside the OT. So third degree heart block, there is complete dissociation between the atria and the ventricles. Atria, they conduct impulses on their own and there is escape rhythm. We call it as a idioventricular rhythm. We can see on the ECG. These are white bizarre QRS complexes. They originate from the Purkinje fibers. So rhythm is irregular. Treatment modalities include pacing, or initially we can try atropine, but many times these blocks are atropine resistant. You can give adrenaline or injection isoprenaline. Isoprenaline, many times patient respond to injection isoprenaline, but if they not responding, we have to do emergency transvenous or transcutaneous pacing, and then we can post patient for the permanent pacing. So this is last week one patient came with complete heart block. We have started immediately isoprenaline and patient's heart rate improved. It stays for 24 hours and again patient went up into the complete heart block. Now they have put the permanent pacemaker. So treatment for heart blocks in general, if they are asymptomatic, no treatment, only vigilant monitoring. If they are symptomatic, see the signs of hypoperfusion and try to rule out the causes, correction of the precipitating causes, injection atropine, isoprenaline, and pacing should be started. Atrioventricular blocks, these we know these are RBBB and LBBB, and mostly they are associated with post myocardial infarction in cardiac patients, and they are susceptible to develop the further complete heart blocks as well, or arrhythmias. So causes of AV blocks: degeneration of the conductive tissue, patients of digitalis toxicity, and myocardial infarction. This is the algorithm given by the ACC/AHA to treat the heart blocks, that is sinus bradycardia. Now this chart is not visible, so I divided it into 3 slides. Whenever there is heart rate intraoperatively typically goes less than 50, first identify the cause. See the airway, see the oxygenation, and try to give proper oxygen and maintain the airway. All possible hypoxic and toxicologic causes like drug toxicity, beta blockers, or digitalis should be ruled out. Electrolyte imbalances should be ruled out. Next, still there is persistent bradyarrhythmia, then signs of hypoperfusion. If patient is awake, there is altered mental status, or if under GA you can see hypotension, signs of other shock, and acute heart failure. So we have to give injection atropine. In ACC guidelines, they have mentioned dopamine infusion and epinephrine infusion. Or not responding, consider the expert consultation with the cardiologist and transvenous pacing. These are the drug dosages: atropine, dopamine IV infusion, and epinephrine IV infusion should be started. If there is only bradycardia but there are no signs of hypotension, we have to monitor and observe. So now coming to the supraventricular tachycardias. Now the terminology which we routinely use, supraventricular tachycardia, has been replaced as only narrow complex tachycardia. This is the update of 2025 ACLS algorithms. So what are these narrow complex tachycardia? These are sinus tachycardia, atrial arrhythmias, paroxysmal supraventricular arrhythmias like junctional rhythms or WPW syndromes, and ventricular and the next type is ventricular, that is ventricular tachycardias, fibrillation, and premature ventricular ectopics. These are tachyarrhythmias. So tachycardia with pulse again divided depending on the size of the QRS complexes, that is narrow complex or wide complex, and the regularity of these QRS complexes. The regular QRS complexes with presence of P wave like sinus tachycardia, supraventricular tachycardias, and paroxysmal junctional reentrant tachycardias. The irregular heart rate like atrial fibrillation, atrial flutter with narrow complex tachycardias. Next comes the wide complex. They again regular wide complex tachycardias like supraventricular tachycardia with aberrancy, that is ventricular we call it as ventricular tachycardias. Mainly they are monomorphic ventricular tachycardias, and when they are irregular, they either AF or they are polymorphic ventricular tachycardia or ventricular fibrillations. So in brief, we will not go in detail about the mechanism of arrhythmias. They are either because of the increase automaticity of the other pacemaker cells or triggered activity, or there is abnormal impulse conduction, reentrant tachycardias, and conduction blocks. Coming to the tachycardia, sinus tachycardia. When we call it as sinus tachycardia, when the heart rate is more than 100 beats per minute, it is sinus tachycardia. Rhythm is regular, PR intervals and QRS complexes are normal. The causes of intraoperative sinus tachycardia are mainly hypovolemia, bleeding, anemia, pain. Depth of anesthesia is inadequate. If patient had developed fever, hypercarbia, inappropriate ventilation, or thyroid crisis, or patient may land up into the failure, it will have sinus tachycardia. So treatment is depend on the correction of precipitating causes, and also see any changes in the ECG, whether patient is having any cardiac acute coronary syndromes or cardiac complications. Sinus tachycardia we can treat and they are very well response with the beta blockers, injection ismolol, injection metoprolol, which we commonly use in the intraoperative period in OTs. Sinus arrhythmia is an entity which is normal. So many times you see that with the inspiration and expiration, there are changes in the cycle, but it is a sinus arrhythmia. No need of doing, no need of any treatment in sinus arrhythmia. In hypovolemia, this sinus arrhythmia gets exaggerated, or sometimes the patients with poor LV, this sinus arrhythmia is also exaggerated. Premature atrial contractions. Premature atrial contractions is because there is ectopic pacemaker throwing P waves in between, but they are normal, and generally they don't require any treatment so far. But sometimes if many PSCs are coming and they are associated with any myocardial ischemia, then serious atrial dysarrhythmias can occur. So treatment again, cause directed, we have to see what is the cause of atrial premature beats and correct the cause. If hemodynamically stable, there is no need of any treatment, only vigilant monitoring is sufficient. Paroxysmal atrial tachycardias. In this, the atrial rate is too high, that is up to 160 to 250 per minute. P waves, they are of varied morphology, but QRS complexes are narrow and normal. So, conduction, as there are multiple P waves, abnormal P waves, we cannot measure the PR intervals. Sometimes this is a normal transient phenomena in patients with structural heart disease and it reverts on its own. But in disease hearts or the patients who is having accessory conduction pathways like Wolff-Parkinson White syndrome, these paroxysmal atrial tachycardia can be fatal. So we have to give treatment according to the hemodynamic stability and instability. So the treatment first is, if it is hemodynamic stable but high heart rate, we can give vagal maneuvers. There are two types of vagal maneuvers. The first is carotid sinus massage and Valsalva maneuver, and next is the antiarrhythmic. So how to give a carotid sinus massage? We should give carotid sinus massage unilaterally. That means both carotid sinuses should not do massage, only one side of carotid sinus massage should be done. In old patient, we should avoid doing carotid sinus massage, as there is any carotid plaque can cause post-operative stroke. Valsalva maneuver, if patient is awake, you can explain how to hold the breath and increase the intrathoracic pressure and blow out. Or if patient is under IPPV, then we can give with increasing the valve pressure up to 40 centimeters of water and give the Valsalva maneuver. Junctional rhythm is type of paroxysmal supraventricular tachycardia. Generally, the impulse it produces at the AV node, either it is slow or accelerated, there is no P wave. These are the different types of junctional rhythms, or they also called as AV nodal reentrant tachycardias. Many times you can see the P waves are inverted, called as retrograde P waves, either before the QRS complexes or after the QRS complexes, and many times there is absent P wave. But hemodynamically, patients can hold, they have a good blood pressure, and there is no need of giving any treatment if it is not very fast. If it is very fast, then we can give them the rate limiting drugs like smolol, or if it is unstable, then direct synchronized cardioversion is the first line of treatment. The monophasic cardioversion with 200 joule is recommended. Injection adenosine is also another drug of choice in junctional rhythm. Adenosine is having a short half-life, so 6 milligram bolus, fast push with 20 ml of saline flush is mandatory. If still the junctional rhythm is persistent, you can give repeat doses of adenosine in the increment 12 mg at 1 to 2 minutes interval.
Dr. Ajita, we have to wind up. Yeah,
Yeah.
please. Yeah.
Please give me 5 minutes. I will wind up fast. WPW syndrome, we can see on the ECG delta waves, and we can predict that this patient is susceptible for the pre-excitation syndrome and may land up into the arrhythmias. If it is unstable arrhythmia develops, the treatment of choice is amiodarone. Atrial flutter, it is very characteristic ECG of atrial flutter. The sawtooth appearances of the on the ECG gives us that it is atrial flutter. The atrial rate is very high, but the ventricular rate is controlled, and that is 100. But in atrial fibrillation, the baseline is oscillatory. There are multiple atrial beats, and they can go up to 300 beats per minute atrial, but and at the same time ventricular rate can be high. So the criteria for the atrial fibrillation and atrial flutter. Atrial fibrillation, the classic is irregular pulse, and the ventricular rate response is very high. The etiology of atrial fibrillation developing in intraoperative period, these are the list of causes to which patients may develop atrial fibrillations. The goal of giving treatment to the atrial fibrillation is first restoration of sinus rhythm if it is acute onset intraoperatively by pharmacologically or electrically by giving cardioversion. But if it is a known patient, then we have to control the ventricular rate for good cardiac output with the antiarrhythmic or beta blocker drugs. In post-operative period, this should not be recurrent, so we have to continue the drugs. And while managing all these, we should keep in mind that there can be thromboembolic phenomena and patient may have post-operative stroke. So this is a chart. If it is acute onset intraoperatively and patient hemodynamically unstable, the treatment is synchronized electrical cardioversion of 200 joules. And if patient is awake, we have to sedate him and then give the electrical cardioversion. But if hemodynamically stable, then we can go for the pharmacological treatment. So this is the pharmacological treatment for rhythm control and rate control. So drug of choice is esmolol, metoprolol, and for rhythm control, drug of choice is injection amiodarone. You can use verapamil and digoxin as well, but digoxin takes 6 hours for the rate control. So esmolol and metoprolol, which are cardioselective, are more preferential. So coming to the last part of that is ventricular arrhythmias. These are the ECGs showing ventricular premature beats. So the causes, many times if they are present on ECG strip 3 to 5, they are benign, but they are also associated with the coronary artery diseases, myocardial infarcted patients on digitalis, and electrolyte indulgences, and intraoperatively hypoxemia may cause ventricular premature beats. So this is a patient with inferior wall MI posted for right coronary artery plasty, and it shows such types of premature ventricular beats. This is post ASD repair patient inside the routine, also showing premature beats. The cause is hypokalemia. So if we see on pre-operative ECG that there are ventricular ectopics, we should evaluate in detail for the structural heart disease, and we can ask them for the 6-minute walk test so that the induction of stress, whether there is increase in ventricular premature beats or not, we can assess. If there are hemodynamic changes, we need to give the treatment. When they are becoming more than 6 to 10 per minute, we should treat and we should rule out the causes. Most common intraoperatively electrolyte imbalance and hypoxia are the causes. So the pharmacologically, we can give the drug is injection lignocaine, that is 1.5 to 2 mg per kg IV. It will respond to lidocaine. If not respond, then antiarrhythmics we can give. Amiodarone, again you can try. These are the ventricular tachycardias, monomorphic and polymorphic. In monomorphic, all the bizarre QRS complexes are of same morphology, but in polymorphic, they are of different morphology. So the rate is high. These are unstable arrhythmias and emergency DC cardioversion, and post cardiac. If they are with pulse, then the SCCAHA has given a algorithm to treat these ventricular tachycardia, and if pulseless, that is cardiac arrest associated with ventricular tachycardia and fibrillation, they have given an algorithm, and in algorithm we should rule out the 5H and 5Ts, which are the hypovolemia, hypoxia, hydrogen ion acidosis, hypokalemia, hyperkalemia, and hypothermia, and 5Ts like tension, pneumothorax, tamponade, then toxicity, and thrombosis like pulmonary or coronary thrombosis. So this is ventricular fibrillation in OT. There is no pulseless ventricular fibrillation. Blood pressure is just 50. We are giving shock.
Yes, sir.
but it's not responding, so we can give again shock. If it doesn't respond to shock, we can give injection amiodarone. Torsades de pointes is again a type of ventricular tachycardia or ventricular arrhythmia. You can see the rapid, irregular, sharp complexes with changing from upright to inverted position and prolonged QT interval. There are many common drugs which we use in our routine practice can cause the prolongation of QTC interval, and patient may land up into the torsades de pointes if with pre-existing causes. So this is the ACLS guidelines or algorithm when tachycardia with pulse algorithm. We have to see for the maintenance of airway oxygenation, and then we can, according to the QRS complexes, we can either go for the pharmacological interventions, or if hemodynamically unstable, then we have to go for the electric cardioversion. This is I have taken in different slides so that we can read. Depending on the wide QRS complexes, you have to treat these tachycardias. This is adult cardiac arrest algorithm, ventricular fibrillation, pulseless patient, give oxygenation, and then you have to assess according to the shockable rhythm or not shockable rhythm. After 2 shocks, even if the patient is not responding, you have to give epinephrine, then again give shock. After 3 shocks, if patient is not responding, then you have to give injection amiodarone and continue for the CPR. So these are the dosages of drugs and rule out the reversible causes like 5H and 5T. In summary, if you know that your patient is having pre-existing arrhythmia, you have to cure with consultation of cardiologist. Intraoperative development, prevention is always better than cure, and if it all occurs, termination with the pharmacological drugs or electrical cardioversion. And to reduce the ventricular rates in these arrhythmias, we should have drugs. 3A's, please remember 3A's, that assure adequate oxygenation and ventilation throughout intraoperative period. There is alteration in depth of anesthesias, and assure optimum ABGs to avoid the arrhythmias. And get AP, that is antiarrhythmic drugs, anti-ischemic drugs, and pacemaker and DC defibrillator with you always. Thank you. And sorry for I took
That was a very exhaustive lecture, Dr. Ajita. So here I will like to have a comment within a fraction of second because I will not take much time. See, arrhythmia, they are worrisome when they occur, more when you are not prepared, especially the patients of ASA1 and ASA2. So when the patient is having the preoperative arrhythmia, or you are anticipating, then you are fully prepared. So what is to be done that time when you are not prepared with the thing? So usually we should first do all the correctable causes should be corrected, and we have to avoid the combination of drug combination of anesthetic drugs, which may cause bradyarrhythmia or tachyarrhythmia. For example, if we are using the fentanyl, propofol, so then you can try to avoid using vecuronium in the same patient, or else the other drug combination like vitamin or atracurium, and you are using for the fast acting the desflurane kind of thing. So there are also the chances of arrhythmia. So there you have to alter this drug combination. And rest everything Dr. Ajita has explained. So these are the comments from my side.
Thank you, madam, for your valuable inputs.
Yes,
Yes, ma'am.
thank you, ma'am. Just short comment from Dr. Lalit Kumar, sir.
May I, sir?
Hello.
May I?
Yes,
Yeah,
Yes,
yes, sir. Yes, sir.
Yes,
You.
sir. Very well covered by Dr. Ajita, and Madam Sanjita has mentioned very well. One for the PG students and the private practitioners who are alone, or whether in working in the corporate or colleges, it is mentioned that we have to do cardiac consultation. So when we are taking these kind of patients for non-cardiac surgery, very well established some cardiac disease is there, diagnosis is there, so we can able to know the availability of our cardiologists. If needed, their expertise in OT. That is one benefit, more benefit that when we get the cardiac consultation prior. Along with the prerequisites, we have to prepare our OT with the drugs. Mostly we are nowadays using glycopyrrolate. So atropine maybe or may not be somewhere available. So we have to keep and the working deflator. All other things, Madam Sanjita has covered. Very nice, elaborated lecture. Thank you.
Thank you, sir.
Okay, thank you, sir. Thank you very much
Thank you,
for
sir.
your inputs. We'll proceed for the next lecture. We'll take
Now
question answer at the end.
now I request Dr. Shilpa Tivaskar to Dr. Sachin Chandorkar to introduce the next speaker. Hello, Sachin.
Good evening, madam.
Huh.
Yes, Sachin,
I
please
introduce the next speaker,
introduce
Dr.
our next
Samrat
speaker.
Mandnaik.
Yes. Welcome, Dr. Samrat Matnaik, sir. He is an associate professor and consultant cardiac anesthesiologist. He is a consultant cardiologist at Dubai Health Authorities presently. Sir is a DM in cardiac anesthesia. He is a fellow of Indian Academy of Echocardiography and echocardiography with fellowship in cardiac critical care, echo and ECMO. Sir, having a PG certificate course in clinical echocardiography, have a level 2 transthoracic echocardiography accreditation from the Indian Academy of Echocardiography. He got Best Academic Achievement Award in 2018. He is a gold medalist in health research exam conducted by Indian Council of Medical Research in 2018. He is a part of the cardiac team that performed first successful uh, adult heart transplantation in KLE Hospital, Belgaum, and was felicitated by KLE University. He is also selected through MPSC and he was felicitated President Appreciation Award by SAMS in 2024. At presently, he is a faculty of at state and national conferences. And he also having American Heart Association certified BLS and ACLS instructor. Sir, please continue.
Thank you, sir. Yes, thank you, sir, for the very kind introduction. I'll just start sharing my screen. Is my screen visible right now?
Yes, sir.
Yes.
Yeah,
You
just a
are
second.
started sharing.
Yeah, I have started my screen sharing. I hope it's
Yeah,
visible.
we can see it.
Yes,
Yeah,
visible.
yeah. So, yeah. So, good evening, respected dignitaries, my seniors, colleagues, and dear friends. Myself, Dr. Samrat. At the outset, let me thank SAMS Maharashtra, all the respected office bearers, ISA National, and all the ISA branches for giving me this opportunity to present at this prestigious platform. So, in the coming some time, I'm going to take you in the world of intraoperative hypotension. My disclosures, anything wise in the presentation, you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error. I'm not associated with any commercial companies and I'm sharing these insights based on my personal understanding. So these are the objectives of my talk. First, I will go through history and definition of intraoperative hypotension. We'll look at the different outcomes. We'll look at a few prediction algorithms and there is a take-home message. I always wonder how they used to anesthetize the people in olden days. Maybe it was like this. Well, I'm glad I'm not in that era or this talk wouldn't be happening. A bit about history. In 1946, Gardner knew that inducing hypotension intraoperatively can reduce intraoperative bleeding. So this is one article from JAMA way back in 1946. His work was taken further by Enderby in 1950s, and he again tried to use intraoperative hypotension to reduce the surgical bleeding. Over the years, over the decades, intraoperative hypotension was used as a method to reduce the surgical bleeding. There was one anesthesiologist, R. Larson, And he found out, he was a German anesthesiologist, and he found out in 1995 that a few subset of people, especially the elderly, who had underlying diseases, did not tolerate this intraoperative hypotension very well, and they landed up in different complications in the post-operative period. So this was the first time when the hazards of intraoperative hypotension were documented. Now, if you look at this picture, what do you see? You see a man who is being scared by a monster. Similarly, whether intraoperative hypotension is really a monster or are we making a mole out of that monster, let us see in the coming few slides. Now you would be asking me, what is this slide doing here? So here I have put few slides of the marriage, and then there is an image of the intraoperative period. Now why I put these slides are, there is no particular definition of marriage. There is no one particular definition of marriage. Similarly, there is no in life. Similarly, in the life of an anesthesiologist, the intraoperative period is an important part. Now, if you go through literature, you will find that there are n number of definitions of intraoperative hypotension. So different researchers have tried to come up with different definitions for intraoperative hypotension. As such, a few wise men said that what is marriage? So it is a relationship in which one person is always right and one person is the husband. So as these wise people define marriage, a few wise people also have come up with a consensus about the definition of intraoperative hypotension. But even after that, even after going through 140 definitions in 130 articles, we commonly say that when the systolic blood pressure is less than 80 the incidence of intraoperative hypotension can lie between 5 to 99%. And as of now, there is no consensus on the definition of intraoperative hypotension yet. So at current moment, there is no one standard definition for intraoperative hypotension. Now, if you look at this image, what do you see here? So you see few people are rowing the boat. They are rowing the boat in harmony. So in the similar way, for circulation to occur in the smooth way in the human body, four factors are very important. One is preload, one is contractility, one is afterload, and then there are a few other factors. So all these factors have to work in harmony to have a proper circulation in the human body. Looking at the intraoperative hypotension, there are different etiologies for intraoperative hypotension. So what are these etiologies? So intraoperative hypertension can occur due to reduction in fluid load, which can be due to vasodilatation, it can be due to hypovolemia, venous pooling, or there can be other causes. It can be due to reduction in cardiac contractility, which can be due to cardiac ischemia or a few adverse effects of the anesthetics. It can be also due to reduction in the afterload, that is due to the anesthetic agents or central neuraxial blocks. And it can also be due to other causes like pregnancy, positive pressure mechanical ventilation, pneumothorax, or embolisms. Now, let me take this first slide over here in this first monitor. What do you see here? So, if you see here, the cardiac output is 2.1, which is quite low. If you look further, the stroke volume variation is 18, and the stroke volume is on the lower side. The SVR is somewhat towards the normal side. So, what could be going wrong in this patient? Any guesses? So, I'll give you some more clues. So I'll show you some echocardiographic images. In the first image, if you see here, this is a subcostal view. And if you see, this is the IVC, which is collapsing very nicely. The IVC diameter appears to be normal. We have measured the IVC over here. And if you see, the IVC diameter is 1.3, which is normal. And there is more than 50% collapse during respiration, which again indicates that this patient is underfilled. If you look at, this is one of the transesophageal echocardiographic images. And if you see here, both the papillary muscles are coming towards each other. We call this as kissing papillary muscles, which is again indicative of a low of the patient or a deficient preload to the patient. So basically, this patient will require some fluid resuscitation and his hemodynamics will improve. So vasopressors or other things are not contributory to this hypotension. Here, the treatment for this patient is volume infusion. Let me take you to another example. Now, another patient, here you have a cardiac output of 2, which is again low. The heart rate is around 138. The arterial blood pressure is around 71 by 60. Mean arterial pressures are 63. The CVP is around 21. So this hemodynamics are towards the deteriorating range. So what could be going wrong in this patient? So for this, again, I'll show you some echocardiographic images. So this is an apical four-chamber view. This is a transthoracic image. So if you see here, I've done some advanced strain imaging in the same patient. The GLS over here is minus 1.0, which is very low. If you observe keenly, the distal IVS, the apex, is not contracting, rather it is akinete. So basically, we are dealing with the problem of contractility in this patient. And here, infusing volume to the patient will actually be detrimental. So the treatment of choice in this patient would be inotropic support, maybe in the form of dobutamine or epinephrine. So this is how treatment differs. The reasons of hypotension differ in different subset of patients, and treatment differs accordingly. One more example. Again, in this patient, if you see the cardiac output is 2.4, the heart rate is quite high, it is 114. The arterial blood pressures are towards the lower side, it is 97 by 69, and the CVP is quite high, it is around 18. Now I'll show you some more echocardiographic images. If you see here, this is hypertrophied left ventricle. So first one was a short axis image, and this is the apical four chamber view. So this LV is completely hypertrophied. If you put pulse wave Doppler across the LVOT, or if you put a continuous wave Doppler across the LVOT, you will find a typical pattern in this patient. This is called as a diagonal pattern, and this is classically seen in patients with hypertrophic obstructive cardiomyopathy. So for this subset of patients, the treatment is not going to be inotropes. Definitely no. The treatment in this patient is volume resuscitation along with control of the heart rate. We want this patient to be adequately loaded along with the heart rate towards the lower side. So this is how actually echocardiography and many other parameters can help you identify the etiologies and guide your treatment accordingly. Now, there was one trial, which was a POISE trial, which was done way back in 2008. And earlier, they used to believe that giving beta blockers to all the patients was really good and it will prevent all kind of cardiac events in the intraoperative period. When they did this trial in 2008, in about 8,351 patients, they found out that the metoprolol group patients actually had worse outcome, and the incidence of stroke was quite high in the patients with metoprolol group. So this was like celebrating beta blockers very early, even before the results were out, and the results were actually very contradictory. So what I mean to say here is never celebrate too early, or you will end up into difficult situations. So same is the thing with intraoperative hypotension. In the intraoperative period, never try to say that you have done a case successfully, because you have to be very watchful till the patient is mobilized in the ICU or towards the OPDs, towards the wards. Now, like there are 5 elements in the nature, there are 5 main outcomes of the intraoperative hypotension. So what are these 5 main outcomes if a patient lands up into intraoperative hypotension? Let us see. So first and important foremost outcome is stroke. So Bitsker et al. In his study found out that if there is intraoperative hypotension, which was defined as 30% reductions in mean blood pressure, then definitely there was higher incidence of stroke. Regarding delirium, a lower mean arterial pressure of less than 55 mm of Hg was associated with delirium, and fluctuations in blood pressure and longer duration of surgery had definitely more incidence of delirium in patients posted for non-cardiac surgeries. Regarding acute kidney injuries, again, a study was done by Wash et al. And they found out that AKI incidence was more when intraoperative mean arterial pressures were kept below 55 mm of Hg. So if you see this curve, this is a sigmoid-shaped curve, and we have the MAPs on x-axis and probability of AKI on the y-axis. If you see here, if the MAP reduces below 55, then definitely the probability of AKI increases. Similarly, there was one another study which was done by Sun et al. For AKI, and it was a very large study comprising of about 5,127 patients. And again, they found out that if the mean arterial pressure was less than 60 mm of Hg for more than 20 minutes, or less than 55 mm of Hg for more than 10 minutes, then definitely the incidence of AKI was high. The fourth important outcome of intraoperative hypotension is myocardial injury. And no doubt, if the systolic blood pressure is reduced by more than 50% from the baseline for more than 5 minutes, then incidence of myocardial injury in the post-operative period increases, or rather in the perioperative period, it definitely increases. This is what literature says. Now, always remember, when dealing with patients in the intraoperative period, you have to be very watchful. Don't land into such a situation, or it will be like digging your own grave. Regarding the last and the important outcome of intraoperative hypotension, that is mortality, there was a study done by Monk et al. And they found out that when the systolic blood pressure was less than 70 mm of Hg, or if the mean arterial pressures were less than 50 mm of Hg, or if the diastolic blood pressures were less than 30 mm of Hg, definitely the association of intraoperative hypotension and mortality, 30-day mortality was quite high. So this was a study done by Monk et al. Similarly, intraoperative hypotension and 1 year mortality. This was a study conducted by Bichker et al. And in this observational study, they showed that there was no causal relationship between intraoperative hypotension and 1 year mortality after non-cardiac surgeries. And the effect of intraoperative hypotension on 1 year mortality remains debatable. So, if you look at 1 year mortality in patients who had intraoperative hypotension, there are two schools of thought. Some say the incidence is quite high. Some say that it has no causal relationship with the mortality. In pediatric population, there is no consensus as to what constitutes of intraoperative hypotension. In children, O2 saturation takes priority over BP during induction, and respiratory events are still the major cause of anesthesia mortality in healthy children. Now, there is a concept of triple low in anesthesia. So basically, what was this concept? If the mean arterial pressures were less, that is less than 65, if the BIS values were less, and if the MAC values were less, earlier they used to say that this combination, that is the triple low, caused more hazardous or deleterious features in the patients in the post-operative period, like different outcomes. It can be any of the outcomes, like AKI, stroke, or whatever, the 5 outcomes that we saw. So this was called as triple low. Now, what do you see in this image? Students are studying, they're sitting on the chair, but they're sitting on the wall. But if you change your perspective, you will understand the truth. So similarly, I'll show you a few images. Earlier, we used to say that a normal blood pressure, that is, you see values on the monitor which are normal, that means everything is okay. So I'll show you one first image over here. This is intestinal gut microvilli, and this is the microcirculation which is occurring in the intestinal villi. If there is hemorrhage of about 10%, this is how sluggish the microcirculation occurs. Again, with 20% hemorrhage and use of some vasopressors, even if the numbers on the monitor look all right, this is what actually goes at the microcirculatory level. So the recent concept is, even if there is a normal blood pressure on the monitor, it does not mean that everything's okay. So if you have hemorrhage along with vasopressor use, and if you have normal values on the monitor, that absolutely does not mean everything is going all right. Now, as such, is there any need for prediction? So if you see in this particular study or this particular example, time has been plotted on the x-axis and the mean arterial pressures are plotted on the y-axis. So we have started the surgery, and if this blue line is actually what has happened to the patient. So this is the mean arterial pressure of the patient, which actually went throughout the surgery. At around 10th minute in the surgery, the mean arterial pressure started to decline. This red dot is when the anesthesiologist has intervened, and after his intervention, again the mean arterial pressures have picked up. Now, what if I say we could diagnose that this hypotension is going to occur, but we could diagnose it sometime before over here, and what we could prevent this episode of occurring? So, is that possible? So, if we could have predicted at this time that this event was going to occur, then we would have prevented this curve going down here. Instead, the patient would have trended on this green dotted line over here. So, the question is it possible? So previously, the Socrates used to predict the future. Any Marvel fans over here, they know how Doctor Strange predicts the future in the Marvel movies. The exit polls are so accurate these days that even they tell how the results can be. And even in cricket, all the captains predict the pitch before going for the matches. So is it possible that we can predict this hypotension which can occur intraoperatively beforehand only? So till date, we were all relying on this advanced monitors which showed us different parameters. But now with the advent of HPI, that is hypotension prediction index technology, it basically predicts a patient trending towards an hypotensive event. So the answer is definitely yes. So all these years we were in descriptive phase. Now we are slowly moving towards the predictive phase. And in future, in coming few years, definitely there is going to be prescriptive phase. So let me tell you in short what this HPI is all about. So basically, Samir Kendare, he had tried to see whether after post-induction, whether hypotension can be predicted. This hypotension can be predicted beforehand only. and studied about 13,323 patients. And based on machine learning algorithms, they found that these machine learning algorithms had a positive predictive value of about 96%. Based on these studies, what the researchers did was they looked at the different curves of the arterial traces, and about 2.6 million features of these arterial traces were studied, and out of the 62 features were selected, and out of this 23 most predictive features were taken into account, and with these features the HPI was developed, or the birth of HPI was done. The HPI prediction model was developed by Hati Bital with the help of machine learning, and basically, HPI, that is hypotension prediction index, can predict a hypotensive event defined as a mean arterial pressure of less than 65 mmHg for more than 1 minute, 5 to 15 minutes before it occurs, actually. So basically, you can predict with this software or this technology whether the hypotension is going to occur 5 to 15 minutes before actually the hypotension is occurring. So more the HPI value, that means that definitely there are high chances of hypotension which is going to occur, and that is going to occur too soon. So for example, if you have an HPI value of 85 or 89, that means in the coming 5 minutes, you are definitely going to have a patient who is going to land up into hypotension. If you have an HPI value of 95, then definitely in another 1.3 minutes or 2 minutes, the patient will land up into hypotension. So how does the HPI monitor look like? So it looks like this. There is an HPI value on the monitor. And apart from this, there are a few other parameters like the SVV, that is the stroke volume variation, which is a measure of the preload, the dP by dt, which is a measure of contractility, and the EA that is the measure of afterload. So all these parameters are seen on the HPI monitor. Now let me take you through an simulation. For example, so we have a patient, a surgery ongoing over here. Initially, the blood pressure is quite good. It is 114 by 64. We have a good HPI value, that is 34. So that means patient basically is not going to have hypotension in the current time. Now, slowly, when the numbers are looking good, the HPI values is increasing. It has gone to 69. After some more time, it is going to increase more. It is 87. Now, definitely this means that patient is going to land up into hypotension in the coming 5 to 15 minutes. So let's see what happens further. Now, HPI values are going to go further more or further up. Let us see. Now it has gone to 95. You see, there is a drop in hemodynamics, slight drop in hemodynamics. So what? Let us do one thing. Like let us see the advanced screen on this monitor. So if you see here, the SVV is 18, the dP by dt is 520, EADine is 1. So SVV basically it is a measure of preload. So let us try and give some fluid bolus to this patient. So now let us select some crystalloid and we'll give some crystalloid to this patient. Now the crystalloid is being infused. So what happens now after giving crystalloid, the HPI value has gone down and slowly your blood pressure is increasing. So we have predicted beforehand only that the patient is going to land up into hypotension, and we have taken corrective measures beforehand. So this is the beauty of this technology. Now, in coming future, definitely there is going to be prescriptive domain that is we are going to, with the help of artificial intelligence, there are going to be a lot of gadgets which can be connected to all these pumps and all your fluids. And basically the machine or the AI itself will tell us and itself will deliver a fluid boluses based on the defined protocol. So this technology is currently under development and very soon it is going to be there. Now, most of you will ask me, for this all technology, you will be requiring invasive arterial blood pressure monitoring, which is not feasible in most of the non-cardiac surgeries. But the answer to this question again is no, because there is a non-invasive cuff over here which is placed, and based on with the help of this cuff, which is based on the volume clamp technique, we can have a real-time bit-to-bit monitoring of the patient, and HPI can work very well even in non-invasive monitoring. So in non-invasive monitoring, this is how the screen looks like. We have a cardiac index, we have an HPI value. These are the advanced monitor. If you see here, this is the trace, bit-to-bit trace, but we have not inserted an arterial line. Rather, this is a non-invasive device which is based on volume clamp technology. So all of these technologies are available. What does the study say? The hypotension prediction index has been shown to reduce the exposure of intraoperative hypotension. However, still studies are ongoing. EU Hyprotect was one such study which was recently conducted, and they found out that HPI software monitoring may help reduce the duration and severity of intraoperative hypotension in patients having non-cardiac surgeries. Now HPI, this is how it looks like. Definitely from this part, like the previous monitors which we had this, now some advanced monitors are available in the market, and this HPI definitely can guide us and tell us how the patient will trend in the intraoperative period. Now look carefully at this image. What do you see here? A politician is trying to talk to the people in the flood affected area. A child is being subjected to violence. But is it the truth? Well, absolutely no. So similarly, you should also know that HPI is not foolproof. So there are a few studies which are showing or which say that the performance of HPI may be overestimated due to selection bias. And again, this is a matter of debate. But overall, this is a good technology which can actually help us predict the trend of the patient in the intraoperative period. Like HPI, there are a few other devices which are based on electrical impedance or pulse wave transit technology, again, which can show us real-time monitoring of the patient. And all these devices, again, are non-invasive. So all these are available in the market. Can echo predict hypotension? So a few studies have been done, have been taken place, and they say echo definitely can predict whether hypotension is going to occur. And the left ventricular outflow tract, that is delta VTI, and the inferior vena cava collapsibility index are two such indices which are a very good marker or predictor of patient who can have hypotension in the intraoperative period. The research is still going on. Similarly, for a preload assessment, we look at the IVC size, the SVC variation, or the peak VTI variations. All these things can be used for preload assessments. I'm not going to go into the details because there is dearth of time. Echo and hypotension, yes, as I said earlier, definitely echocardiography bedside in the intraoperative period in non-cardiac surgeries, again, which can be performed and it can predict and guide the patient treatment in the intraoperative period. A few of my clinical experiences. So I had this one patient who was posted for RFA ablation, which is a vascular surgery. Basically, uh, my surgeon required general anesthesia for this procedure. Most of you must be doing it under tumescent anesthesia, or a few of you under spinal anesthesia also. But my surgeon required GA, so I had intubated this patient. Sometime after induction, I had some hypotension in the patient, and there were very subtle ECG changes. So, fortunately, this patient was taken inside the cardiac OT, so I had a T probe in place. I inserted the T probe, and to my amazement, I found that there were decreased strain patterns in the inferior region of the patient. So I asked my surgeon to wrap up the procedure early, and I had to give him a dose of heparin, and I also started some nicorandil for this patient, and wrapped up the surgery early. And fortunately, during this surgery, there was no problem. And in the post-operative period, when we did an angio, we found a lesion into the RCA. So basically, echocardiography can help you to diagnose the etiologies and guide the patient management in the intraoperative period. Another patient, this was a case which was operated for IT fracture femur, and in the postoperative period in the wards, the patient suddenly had dyspnea on the PO day 3, and when we evaluated this patient, we found that the RA and the RB was dilated, and this is again a TE image, and you can see a pulmonary embolus sitting into the right pulmonary artery of this patient. Another patient who had RCC and who had an IVC thrombus, which was in the hepatic part of the IVC. This case was basically posted for an left upper arm embolectomy. And basically, we inserted the T probe just to look or keep a watch on this IVC thrombus. Another example, one patient, ASA grade 2, 45 years old male, he was posted for umbilical hernia repair surgery. And in this patient, I usually have the habit of doing a preoperative screening, echo screening for all patients. What I found was he did not have any symptoms, but the RA and RB was dilated. So I did a proper screening, and what I found was the patient had sinus venosus ASD. So this is a T image of the same patient. Basically, this is the interatrial septum, and this is the sinus venosus ASD over here. This is the left to right shunt. This is a 4D image of the same patient, what I have tried to show you. And this is from the LA perspective. What you can see here, this is the sinus venosus ASD. And again, these are the 4D flow quantifications of the same patient. So basically, we did not subject this patient first for hernia repair surgery. Rather, he went a sinus venosus ASD repair surgery first, and then I underwent a non-cardiac surgery. So nowadays, these automated portable echo devices are available, which can be used bedside and which can actually help us in the intraoperative period. So always remember robust monitoring is always important especially in high risk cardiac surgical patients, which can include the invasive monitoring, PA catheters, the echo probes, the transesophageal echocardiography probes. All these things can be utilized. Just a word about how actually intraoperative hypotension can be treated or how we go about it. So basically, or in short, if we have a mean arterial pressure of less than 65, or if there is 20 to 50% changes in the baseline or reduction in the blood pressure from the baseline, then always remember you should consider or you should try to diagnose different causes. This can be diagnosed with the help of echocardiography. Based on this, your treatment can be guided. So either preload infusion or for improving the contractility. If the contractility is low, then you can start with some inotropic agents like dobutamine or epinephrine. You can always adjust the anesthetic drip. And in some subset of patients, if optimization is not addressed or not done properly, then you can address or consider some specific problems like arrhythmias or pneumothorax or cardiac tamponades, which again echocardiography comes or plays a big role in diagnosing all these conditions. So this is a brief overview of how you can actually treat a patient with intraoperative hypotension. So my take-home message is a systolic blood pressure of less than 90 mm of Hg, a diastolic blood pressure of less than 45 mm of Hg, and a mean arterial pressure of less than 65 mm of Hg is associated with poor outcomes. There is no definitive answer for what is too low or too long as regards to intraoperative hypotension. Predicting, preventing, and managing intraoperative hypotension is a skill which everyone should master. You should get acquainted to newer technologies, especially echocardiography. And in near future, AI is going to guide the prediction and the treatment domain. Now, I begin my talk by comparing marriage with intraoperative hypotension. So, I always say that if you ignore intraoperative hypotension to a small extent, definitely there are going to be some problems, small problems. If you are going to ignore it for quite a longer time, definitely the problems are going to be very crucial or significant. For a good outcome, you should always remember that never ignore intraoperative hypotension. For a good outcome, you should respect the macro as well as the micro circulation. These are a few of my references. Thank you.
Yeah, thank you, Dr. Samrat. That was very nice talk and with illustrative examples how to use the various gadgets like echocardiography and the advanced hemodynamic monitor. Here I will like to have few words here that the happening or the hypertension during perioperative period, the incidence is quite high in especially in anesthetized patient, and it is a multifactorial. However, what is dangerous is the fluctuations in the blood pressure, the hypo or hypertension that is more causing harm than only hypotension or only hypertension. And that will have to, because there is a oxidative stress, and that oxidative stress will reduce the perfusion of the vital organs, so one has to take care of that. And the patients, especially when they are on various antihypertensive drugs, they are more prone for, they have a precipitous fall in blood pressure in the perioperative period than the other patient. So we'll have to evaluate the patient whether it is a preload responsive or not. So simple tests like the passive leg raising, if you do in the preoperative period, you will come to know whether we should give fluid for this hypertension or not. And also if we are doing the continuous blood pressure monitoring, the pulse pressure variation is also is a good value or the parameter to know, and the area under the curve. When you are doing the continuous blood pressure monitoring, the waveform itself will tell you whether the peripheral vascular resistance has reduced or is increased. Because what you see is the blood pressure is not the always everything is right as you correctly mentioned. So you don't know what is the problem which is causing this hypotension. So we have to look into the depth, and then your echocardiography and also the advanced hemodynamic monitor has a role. So I think these are the comments from me. Over to sir.
Absolutely, ma'am. Agreed. Absolutely.
Yes. Thank you, madam. Um, that means as a Gynecologists learn the UAG machine. Every anesthesiologist should have expertise in echocardiography. It is not difficult. If they are doing so much, then it is not difficult to mm, learn the echocardiography. It will be very useful to you. Yes, sir. What
Absolutely,
is
sir.
your opinion about this hypertension?
Sir, absolutely well said, sir. Now the time actually has come when I feel every one of us, even the non-cardiac anesthesiologist, should master the skill of echocardiography, because this is one tool which actually helps us to understand the etiology and helps us to guide the treatment, proper treatment towards the patient. All these years we were just relying on the different parameters based on the different values we saw on the monitor, and we were making a guess as to what is going wrong. With the help
Mainly,
of
it is
this
non-invasive.
echocardiography, yes, non-invasive,
Yes.
absolutely. And with this HPI technology, as I discussed before, as earlier, in this HPI technology also there are different parameters or advanced screens that you see. One is a SVV, one is the DP by DT, and one is EADI. So based on these parameters also, it helps us to tell or guide the treatment to the patient. For example, if a patient has SVV value which is quite high, definitely then that means this patient is having preload deficiency. If the DPP DT value is low, that is basically less than 400, as we call for the HPI technology, that means something is going wrong with the contractility, and you need to add some inotropic agents to this patient. Iodine again is one value which tells us whether the patient is going, his actual hemodynamics are going to improve if you're going to give fluid to this patient. So if the iodine values are towards lower side, then that means the patient is not going to respond to your fluids. If the
Yes, Lalit Kumar sir.
Yes,
Hello.
sir. Very
so
well
this
explained
is
by
how
Dr.
technology.
Samrat.
You want to add anything?
Yeah.
Just that everywhere, if we are not having echo, we can have high-end cardiac monitor that have the non-invasive cardiac output.
Yes, sir.
Agree, Dr. Samrat?
Yes.
At least we should have minimum requirement. Yes, I do
So,
agree. Yeah.
yes.
Yeah. The only thing I will like to add here that the not only systolic blood pressure but diastolic blood pressure also, because if it goes below 60 millimeters mercury, then the coronary perfusion may get hampered. So one has to look for, because ultimately hypotension, the diastolic hypotension may cause coronary ischemia, and that will further aggravate the hypotension.
Definitely,
Okay,
madam.
thank you.
Thank you very much. Now I request Dr. Shilpa Tivaskar to introduce our third speaker, Dr. Amol Kulrekar, sir. एक मिनट.
It is proud privilege to introduce Dr. Amol sir,
थांब.
Amol Kodulkar sir.
Yes, Shilpa, you
Hello.
Okay.
you have short
Hello, yeah.
introduction.
Okay, I have the introduction. I'll start that.
Please.
Sir is senior consultant at Anesthesia and Critical Care Aster Aadhar Hospital, Kolhapur. Sir has over 25 years of experience, clinical experience in perioperative care, regional and general anesthesia, critical care management, and advanced airway management. Sir is actively involved in quality improvement, patient safety, ICU management, and teaching for postgraduate trainees. Sir is past president, Indian Society of Anesthesiologists, Kolhapur. Sir is past president, IMA Kolhapur. Sir is an ACLS instructor and IDCCM teacher, that is Indian Diploma in Critical Care Medicine. Areas of expertise are advanced airway management, regional anesthesia, critical care medicine, high-risk surgical patients, cardiac and trauma anesthesia, teaching and training in anesthesia and critical care. We welcome you, sir. It's a privilege to hear from you. Thank you.
Welcome, Dr. Amol, sir.
Yeah, pranam and good evening to all of you. Indeed,
Good
it's
evening,
my
sir.
great pleasure. And am I audible?
Yes, you are
Am I
audible.
audible?
Yes,
Please
yes.
continue.
Okay. It's a great privilege and pride to be with you on this webinar. and thank you for this kind words. I'll be talking about the perioperative myocardial ischemia in a non-cardiac surgery. What we have listened, arrhythmia and hypotension in a perioperative period, whether it is a cause or whether it is a result of this myocardial ischemia, we'll try to find it out. We are very much proud that anesthesia is the only fraternity which has reduced its mortality to a significant level, but not towards zero. And more than 300 million surgeries done across the globe. Out of that, 30% of patients have a cardiac disease here. This is the tip of the iceberg. What we find is 9-fold increase in the mortality happens. There's 32-fold increase in the morbidity of this subset of coronary artery disease patients coming for surgery, non-cardiac surgery. There is a poor cardiac outcome in almost 50% of these patients. Long-term prognosis is bad and cost escalates by about more than 50%. When it was said that perioperative MI or intraoperative myocardial infarction, very difficult to diagnose, difficult to define is also. And traditionally, what we describe myocardial infarction or ischemia as symptoms, or there are ECG changes, either ischemic changes, that ST depression or ST elevation. There can be development of pathological Q waves, or in the imaging, there should be new loss of viable myocardium on echocardiography. In perioperative period, when patient is sedated and anesthetized, it's very difficult to find it out. And the fourth universal definition that has come as a perioperative myocardial infarction is on basis of cardiac troponin. So cardiac troponin, high sensitivity cardiac troponin T values increase suggestive of when the value goes more than 99th percentile of the upper reference limit, it is suggestive of myocardial infarction or ischemia or injury. The another concept has come that is means. That means myocardial injury after a non-cardiac surgery. Now here what happens is actually there are no ECG changes. There is no changes on the images also. Like echo, if you see, there is no regional wall motion abnormality. But there is an increased level of cardiac troponin seen in a postoperative period, first 24 to 48 hours. And this is called, this has got a very, very high morbidity and mortality postoperatively in these patients. So cardiac troponin has got a linear relation with the morbidity and mortality. Higher it is present, higher the mortality it persists first 30 days. So morbidity and mortality is significantly high in first 30 days when patient pose high levels of cardiac troponin. Together, myocardial ischemia infarction is a major cause of short-term and long-term morbidity. This is months of surgery. This is group shows low cardiac troponin levels. Survival rate is high. Well, this particular subset, which shows actually high cardiac troponins postoperatively, which shows a very, very high mortality. Incidence in patients of risk of coronary artery disease reported is 20 to 63%. And it differs from pathophysiology. There are two pathophysiology or mechanism that takes place. Before that, I will tell you that perioperative myocardial injury, it can be ischemia, it can be infarction when there is a transmural ischemia, when there is a ST elevation, and there can be myocardial injury when only cardiac troponin levels are in place. Routinely in our ICU, when patient comes with the chest pain and ECG is normal, we get then cardiac troponin I after 6 hours. And if it is elevated, we say this is probably non-STMI, and we don't thrombolize this patient. These patients are subjected for PCI. The clinical manifestations of myocardial ischemia ranges from asymptomatic silent episodes to angina, arrhythmia, conduction blocks. A newly developed LBBB definitely signifies that this patient has got some ischemic heart disease. conduction blocks, yes, newly developed wall motion abnormalities, pulmonary congestion, infarction, and sometimes it can happen into sudden cardiac arrest, death. The two mechanisms they are proposed, one is acute coronary syndrome, where there is a plaque and plaque ruptures. This plaque, there is a pro-inflammatory status and plaque ruptures, then there's the aggregation of the platelet, the endothelial gets damaged, and there will be block, ischemia, hypoxia, and infarction will happen. But not necessarily that it will depend only on the plaque rupture. The plaque rupture can be having extracardiac causes, like a patient who is posted for surgery having high hypercoagulability, reduced fibrinolysis. Patient if has gone under a recent PCI and he has stopped his dual antiplatelet, all these can cause to the acute coronary thrombosis, which is called a type 1 myocardial infarction, which happens in patients who are not posted for surgery. This is routinely very happen in non-surgical patients. What is the cause of surgical patient is very well elaborated recently by Dr. Samrat here, that myocardial oxygen demand supply ratio is imbalanced. When myocardial oxygen demand is increased by heart rate, arrhythmias, myocardial stress, or subendocardial O2 supply is reduced by heart rate, arrhythmia, again, very, very important cause, hypotension. If you remain hypotension for a very long time, then definitely produces ischemia. Even though coronary artery autoregulation is very robust, it cannot happen with the small episodes of hypotension, but hypotension persists for a longer time, then it will definitely produce ischemia, and that will give a type 2 myocardial infarction. So in a perioperative MI, it is most of the time because of demand and supply imbalance of the oxygen, which is very important. Here again, this is type 1, that is because of atherosclerotic plaque, which has got less than 50%. And here, because of oxygen demand supply imbalance, the myocardial infarction in perioperative period goes to 80-90%. What is the basic difference? The typical presentation, hence diagnosis is very easy in non-surgical patients. In perioperative patient, most of the time silent or typical, difficult to diagnose. Commonly occur out of hospital in all surgical patient. ST segment elevation. Here, ST segment is depression most of the time. Q wave in myocardial infarction, this is non-Q. The mechanism is atherosclerotic thrombus obstructing the coronary artery. And here the mechanism is oxygen demand supply imbalance. So these are the types of perioperative is again atherosclerotic plaque. Type 2 is imbalance between demand supply. Sudden unexpected cardiac death with symptoms is type 3. MI associated with PCI or stent thrombosis is of type 4. MI associated with cardiac surgery type 4. And multifactorial, there are extra cardiac causes like renal failure or pulmonary embolism, which can produce MI, and that is type 6. But most common in perioperative period is mechanism is oxygen demand supply imbalance. Looking at the risk stratifications, there are many tests and many indexes are there which has got a sensitivity, specificity, positive predictive value, negative predictive value. But except Goldman's class 4, no one has predicted more than 56% of the predictions. But routinely, for very simplicity, we always try to find out this Leeds revised cardiac index criteria, and all of you know ischemic heart disease, major surgery, emergency surgery, history of congestive heart failure, CVA, insulin, creatinine more than 2, and you can definitely stratify which patient is going to get more problems in a perioperative period, and you have to take more care. The clinical predictors are acute or recent MI, definitely big no for these patients to surgery. They get major problem. Unstable angina, they should go for the cath lab rather than to the surgery. Again, decompensated congestive heart failure, significant life-threatening arrhythmias, and severe valvular heart disease. Yes, patients with mild angina, prior myocardial infarction, maybe 6 months back, compensated congestive heart failure, maybe 6 months back, and diabetes, renal insufficiency post intermediate, and minor like advanced age, abnormal ECG, rhythm, history of stroke, and uncontrolled hypertension. Emergent surgery again depend on very high risk, aortic and vascular surgery, very, very high risk, peripheral vascular surgeries, large fluid shifts and blood loss. For carotid endarterectomy, head, neck, intraperitoneal orthopedics, intermediate surgery, but endoscopic procedure, superficial procedure, cataracts, breast surgeries, you can consider the low risk for these patients. Clinical presentation and diagnosis, infarction in the ST elevated myocardial infarction is very, very rare in an intraoperative way. Very, very rare. At least I have not seen a single. But 80 to 90% of these are asymptomatic and they are perioperative myocardial ischemia. So implication relying on chest pain diagnosis is not possible, and the catastrophic failure or pulmonary edema patient can offer. Diagnostic surveillance is asymptomatic nature. Active surveillance is recommended by high-risk groups. And troponin screening. European Society of Cardiology's guidelines recommended that high-sensitive troponin T has to be preoperatively in the subset of group where coronary artery disease is there. And you should continue this troponin screening postoperatively also, because it will increase even at more than 20% of the baseline. Then it shows that there is a myocardial injury is likely to patient get infarction, or morbidity and mortality is very high. Well-did ECG is recommended. But many times ECG has got limitations because left ventricular hypertrophy, LBBB, pre-operatively or intraoperatively, you cannot diagnose these patients any STT changes. Now, what are the prevention strategies one has to take? If there is a pharmacological, then beta blockers. Dr. Samrat has told about the POISE trial, and there are a lot of actually, rather than advantage, disadvantages are there. Stroke and hypotension are the major cause, and that's why if the patient is on beta blocker for a long time, one should not discontinue. But if at all you want to start beta blocker for this particular patient who has got a coronary artery disease, at least few weeks you have to start. These 4 weeks you have to start these beta blockers and one monitor the blood pressure and hypotension, whether he gets hypotension well or not. Regarding the statins, yes, they are plaque stabilization and they are anti-inflammatory. So the current recommendation, continue statins, but you have to continue at least 2 weeks prior to the surgery. If they are not on the statins, at least 2 weeks prior, you can start. Antiplatelet therapy, aspirin, they have given trial, but none of the aspirin, clopidogrel, or AC inhibitors, ARB blockers, none has shown that improved results. So all they have not strongly recommended. Now, what we have to look into that, how to prevent this imbalance of oxygen demand supply. Obviously, hypoxia has to be avoided. Long spells of hypoxia lasting more than 94% saturation for a longer time, definitely it's deleterious and it is going to produce ischemia in these patients, infarction in these patients. Hypothermia requires higher demand of the oxygen again. So temperature less than 34 should not be tolerated. Hypotension, yes, we had a big discussion on this hypotension, and hypotension is responsible for post-operative myocardial injury or infarction. Anemia, hemoglobin, yes, definitely it gives a good oxygen flux. Hemoglobin is the only thing which carries the oxygen. So in patients of coronary artery disease, strictly you have to have hemoglobin of more than 10. Tachycardia is very, very dangerous simply because it increases oxygen demand and it reduces, because of the diastolic period is reduced, it reduces oxygen supply. And in patients who have got a basal rate of 50, 60, even 90 heart rate is very dangerous for these patients. Not necessarily that it should be more than 100. Hypertension, yes, again, vasoconstriction happens and there is a coronary vasoconstriction, and it will reduce the blood supply to the myocardium. Light plane of the anesthesia, electrolyte imbalance, embolic events, coronary artery spasm, all these are the preventive strategies one has to do to improve the oxygen to the patient. So decreased oxygen delivery, decreased coronary blood flow because of the tachycardia, hypotension, hypocapnia, all these you have to take into consideration. Decreased oxygen content like anemia, if the patient is losing blood, you have to transfuse this blood transfusion immediately. Try to make it more than 10. Arterial hypoxemia, shift of oxygen hemoglobin to the left, again is a problem. Increased oxygen requirement, like increased preload, so that can stretch, and sympathetic stimulation, tachycardia, systemic hypertension, all these will increase oxygen requirement. So over circulation, overload of this patient is also dangerous. So physiological goals to increase myocardial oxygen supply, keep the heart rate normal in between 50 to 80, 60 to 80. High oxygen content of blood saturation, hemoglobin has to be maintained. High normal aortic pressure, reduced coronary vascular resistance, and low left ventricular end diastolic pressure. Physiological goal to decrease myocardial oxygen demand. Again, same normal heart rate in between 50 to 90. Low myocardial wall tension after load, avoid hypertension, excessive fluid administration, and avoid increased myocardial contractility. Anesthesia technique, there is no strong evidence support specific anesthesia technique is preventing myocardial ischemia. High-risk patients such as those who have got recent myocardial infarction or PCI are more likely to have antiplatelet therapy, and for neuraxial blockade becomes tough for them. So rather than technique of anesthesia, conduct of anesthesia is very, very important. And that is opioid induced anesthesia is many times the fever. Now, what happens if we get a catastrophe or intraoperative ST elevated myocardial infarction? Again, very difficult to suspect. Sudden ST changes are there. If there is a hypotension, which cannot be explained, if there is arrhythmias, especially fast atrial fibrillation or ventricular fibrillations, drop in ETCO2, new regional wall motion abnormalities on echo, if you find it out, you can definitely suspect that patient has got probably ST-MI. Then first thing that you have to alert your surgeon about the surgery, call the cardiologist, alert the cath lab, it is present in your institute is well and good. Otherwise, you have to transfer this patient to another cath lab. Start 100% oxygen. Then look whether patient has got a hypotension or hypertension. If it is hypotension, then reduce the anesthetic depth. Small fluid boluses you can go on giving it. If you have high-tech monitoring with this, then according to that, you can put an arterial line. You can have the flow track, and depending on the pressure, you can use the fluids. Along with that, you can start noradrenaline or phenylephrine. If there is hypertension, then deepen the anesthesia. You can start esmolol infusion and start nitroglycerin infusion also. Reduce the myocardial demand by reducing the heart rate. So adequate analgesia or start nitroglycerin by 5 to 20 mics. Antiplatelet, if the patient is conscious, alert, under spinal, you can take, or if he has got a NG tube, through that you can give aspirin 150 to 300 milligram or heparin 60 units per kg, maximum 4,000 units you can give it. Of course, you have to go for the 12-lead ECG, arterial line, TE, all these things. And about surgery, intraoperative thrombolysis, absolutely no. Streptokinase, TPA, inactiplase, all these can produce a significant bleeding intraoperatively, as well as there is a chance of intracranial hemorrhage. At least I have witnessed one particular patient, perioperative patient was having severe pulmonary embolism, and we diagnosed it on echo while we doing resuscitation. And that time we called cardiologist also, and we wanted to take him to the cath lab, but he said, with the resuscitation, it's very difficult to take to the cath lab. We will thrombolize this patient, and we thrombolize that patient with the 50% of the tenactiplase. But this patient post-op, he revived, but post-operatively he had a severe intracranial bleed and he succumbed. So this is becomes a very major decision to thrombolize or not. Of course, we have taken with the help of the cardiologist and did that. Now, how it happens, suspected post-operative myocardial ischemia or infarction, cardiac symptoms, hemodynamic stability, tachycardia, congestion. You can take a 12-lead ECG. Along with that, go for the arterial line, treat hypothermia, hypoxia, hypercarbia, acid-base imbalance, hemoglobin more than 10. Look for the troponin. It should not be done immediately. Troponin elevates later on. Then look for the ST elevation. If it is rare, cardiology consultation and troponin. Consider angiography or PCI here. ST depression is there, then look for the tachycardia and hypertension or tachycardia and hypotension, and you have to treat accordingly. Preoperative interventions for prevention of perioperative MI. Two principal strategies are used in PMI for cardiac events. Preoperative coronary revascularization with PCI or CABG and some pharmacological intervention, but none has proved that they are beneficial in a stable coronary artery disease. And that's why coronary revascularization electively is taken, same indications as a non-recurrent patients. So patient having coronary artery disease who has posted for surgery and he is stable, he has got no symptoms, his echo and everything is normal, then one cannot go for the revascularization. You can go for the elective surgery, but you have to take care of the oxygen demand supply, about all tachycardia, hypotension, everything. That. If at all the PCI is done for a measure like a left main and everything, then balloon angioplasty, you can operate these particular patients in 14 days. Bare metal stent, 4 weeks. Now drug-eluting, they have got third and fourth generation, so you can operate early in the 3 months also. And if you do, this is again not a complete revascularization happens. There is a partial revascularization with this. If you want to do a complete revascularization, it is nothing but the CABG. And after CABG, 10 days, you can take these patients. Recently, we had a patient who was having coronary artery disease, triple vessel disease, but stable, and he wanted to go for a gallbladder cholecystectomy. He was symptomatic gallstones. So what we did only in this last week only, we operated both things simultaneously. We did lap chole first, and after lap chole, of course, we are putting arterial line, central line, then noradrenaline, NTG, all infusion, all parameters, flow track, and everything was there. Everything was uneventful. Then immediately we took him for the coronary artery bypass, and he is doing well. So in conclusion, perioperative myocardial infarction is mainly non-ST-MI and type 2 MI. Predisposing factors high grade, stable coronary artery, prolonged stress-induced ischemia is responsible. Tachycardia, hypotension, and anemia, you have to take care along with the hypothermia, whichever increases the oxygen demand. ST-elevated myocardial infarction is relatively very, very rare despite high prevalence of coronary artery disease in surgical patients. Silent perioperative MI injury is 10 times more common than overt MI. So post-operatively, this patient has to be monitored with cardiac troponin. Nevertheless, short-term and long-term outcome correlates with the peak troponin levels. The peak troponin levels are high. Mortality and morbidity of first 30 days is very high. Patient with preoperative elevated troponin levels, additional elevated levels in the post-operative period was high risk for the myocardial infarction and injuries. So in summary, myocardial ischemia and infarction is a major cause of short and long-term morbidity and mortality in surgical population. ECG has got a limitations. 2D echo cardiac troponin are used for the diagnosis. Identifying the risk patients helps intraoperative planning to reduce the consequences of ischemia. There is no role of prophylactic coronary revascularization in these patients, and attempt to reduce the risk of adverse outcome by implementing aggressive preventive treatment modality of ischemia and infarction. So a good quality of anesthesia, the basic principle of anesthesia laid down for each and every patient has to be aggressively done in these patients of coronary artery disease, which come for the non-cardiac surgery. Thank you very much.
Thank you, Dr. Kodalikar. Very lucid and nice presentation. So, can Madam, are you there?
Yeah. Yeah.
Yeah,
See, excellent
please,
talk. All the aspects of the means they have covered by Dr. Amul. Here, the risk assessment in the preoperative period, we should give more weightage to that using various the recently invented calculator like ACS NSQIP calculator that will help us to certify the risk in the preoperative period. Hence, we can take more measures in such high risk patients, as well as the maintenance of myocardial oxygen demand and supply. One has to take care, and as soon as possible, one has to maintain the hemodynamic stability by various means. It's and the monitoring is crucial in that the lead 5 that is very important to know the any changes that is those are occurring in the STT changes if they are occurring. So lead 5 should be monitored in such high risk patients. So that was from me. Rest is covered by.
Yeah, routinely with
okay.
these patients, we whenever the coronary artery disease patients are coming for this, we arterial line, central line, noradrenaline infusion, and esmolol infusion. These are kept ready, and then we proceed for this.
We can monitor if we are taking the invasive central line, we can monitor the oxygen saturation of
Saturation,
from
yeah,
the taking. Yes, yes.
continuous SVCO.
Okay. Thank you, ma'am. Sir, you want to add something?
No, sorry, it's nicely covered by all three
Yeah,
speakers. They are expert in cardiac anesthesia.
right. Yes, sir.
And
I
very
have,
well said, prediction and preparation is must.
yes. Uh, I had some basic questions. Not that is some people ask, should we take a consultation of cardiologist or physician for this cardiac patient posted for non-cardiac surgery? Which consultation we should send to the patient, cardiologist or general physician?
Sir, it depends as per nowadays with the law. If
Mhm.
cardiologist is available in our institute, preferred
Okay.
cardiologist. Otherwise, we can take physician reference. And if physician says, then we have to take cardiologist, in my opinion, as per law
Yeah,
also.
you're absolutely right, sir. Yes.
Yes. Okay. Next question, it is my questions only. If most of the times that is in periphery or small places or small nursing homes, we don't have echocardiography or a defibrillator. Actually, this should be there, but most of the hospital don't have this defibrillator or echocardiography. So, how should we treat the patient if there is a MI or IHD or hypotension in small places?
Sir, as per Supreme Court guidelines,
Yes,
every
defibrillator will be
OT
there.
should have deflator.
Yeah,
Every
I
OT
know
should
it.
have deflator.
Yes,
But
I
so
know. Still,
if they are
still
not
don't give
having,
a
no, if
yes,
they are not having, then they have not to take that case.
Yeah, they
yes,
should be referred to the higher
yeah,
center.
Yeah,
I want,
definitely.
I
But
want,
then if you are not anticipated and it happens,
yes,
then what? I think his question is
yes, I want to give a message to all through you only. So I ask this question. Second question is still we are using mepentryptamine, that is mepentin for hypertension. So, uh, what is your idea and suggestion to all?
Mostly, it is like a poor infrastructure drug
Yeah.
we can use, otherwise, we have not to use. And one more thing, sir, the Supreme Court has given guideline even for laparoscopic sterilization, that is in remote area. Nowadays, also it's going on. Again,
Yes.
it should not be conducted without defibrillator.
Yes. Defibrillator is compulsory. Yes.
Yes, sir. Even
Yeah.
I am saying, even in the rural setup or mobile camps.
Yeah. Yeah.
Yes.
Yes. Any questions from audience? There is
Dr.
one
Sheetal
question.
madam?
Is it?
Yeah, there is
Yes,
question.
there is a one
yes.
question from the audience, that is it possible to suspect ventricular premature complexes without having ECG?
No, you just get a misfit. That's all. But whether
Yes.
it is because of
Yes.
atrial fibrillation or ventricular, that you cannot predict.
Yes,
Yes,
and
That
also
is
on
here
pulse
unpublished.
oximetry, you can appreciate the ectopics. Pulse
actually
oximeter
I
test.
want to say, as a
Yeah, but
defibrillator,
even
you,
atrial fibrillation, now you get a kind of
yes,
symptom. So you
but
you
madam,
are not sure
what,
whether it is what is the cause of this misfit.
but what I want to say is, as a defibrillator, every OT or every monitor should we should have a ECG monitor.
Yes, sir.
Each
We
and
should.
every
Yes,
patient,
sir.
we should attach a ECG monitor
That
to each
is
and
a
every.
ASA standard
Yeah.
only.
Yes. Yes.
Five
Yes.
parameter standard.
Yes.
Hello.
Yes. One
Before
more
what of
question is,
the question? Okay.
a last question. Role of
Nicorandil.
nicorandil in intraoperative cardiac event.
Yeah, nicorandil, yes. In when there is a coronary ischemia or anticipated, then you can give as a coronary vasodilator, but it takes onset of time is more 15 to 20 minutes it takes, and also it can cause hypotension if the patient is fluid depleted. So, so that is more in the coronary intervention cases. It is more useful than this. Here you can use nitroglycerin, which is immediate action has, but at the same time you have to take care that the the preload is optimized.
Yes.
Sir, there are two more questions.
Hmm?
Neelam madam
Yes,
has asked that,
please.
yeah, drug-eluting stent patient comes for oncosurgery. Cardiologist refuses to stop clopidogrel, saying that bridging will not help. So can we explain more blood loss and take the case, or what options we have?
That is this thing.
Any
We
one of
can
you can
go
take,
for
yeah.
the platelet aggregometry test, the platelet function test. You see there, because getting a only count is not helpful because we don't know how much adhesive they are. So one can go for the this platelet function test and then take a call, because oncosurgery is a kind of semi-urgent surgery. So we'll have.
Yes.
Ma'am, can I add a few points on this if you are permitting?
Yes, yes,
Yes.
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 Yes,
Sure.
please.
Yeah. So if you are looking at the antiplatelets and if the patient has a recent drug eluting stent, basically the reason why the cardiologist would like to say or tell us not to stop the antiplatelets is because there is definitely a risk of stent thrombosis, which is basically platelet mediated. And even if we do some bridge therapy like heparin or low molecular weight heparin, it's not going to a low dose or a dose of clopidogrel can be shifted to aspirin, or IV cangrelor, which is available in the market currently, can be used just for the bridging therapy during the intraoperative period. And per se, MRM is not such a high risk, very, procedure wherein we are expecting very huge blood loss. So either of these strategies can be considered, but definitely I feel that we can proceed for this surgery with a bridge therapy in the form of maybe aspirin or IV cangrelor.
Okay, there is one more question by Dr. Rajesh Rao, sir. Should troponin I and pro-BNP be mandatory in all cardiac patients preoperatively?
I don't
So
think so.
it is not strongly recommended that you have to do a troponin I or troponin T actually, or even a pro-BNP. But you can do a pro-BNP to find out how much a cardiac stress is there with the patient has got congestive heart failure history, and
Yeah, were there recent
that is not
guidelines
recommended in the guidelines.
last year that pro-BNP should be done in all the patients, sir?
Yeah,
Okay,
I think
and
it is added.
one more question by Dr. Neelam, madam. In geriatric patients for fracture neck surgery, it is said that both GA and regional have same outcome. When many GA things are predisposing to cardiac, isn't GA more risky for them? But I think our low EFs, we mostly give GA. What
GA
is the
only.
take of? Yeah, what
Yeah,
is the
yeah.
take of speakers and chairperson on that? Does polypharmacy affect, and should we opt for graded regionals or
Actually,
continuous pipe?
even you can give regional with minimum doses. The hemodynamic stability is there. So there is a very much controversy and discussion. So
More
GA
of a
and
conduct of anesthesia is more important rather than the type.
yeah,
If you do a regional anesthesia without any hypotension, it is always good. You can
yes.
conduct these cases. You can put artillerine, you can start noradrenaline, you can give small dose of the leobupivacaine and conduct these cases with low ejection
Right, sir.
fraction.
Along with
Under
graded
GA,
epidural.
the cardiovascular system is in our control. So
Actually,
management of blood pressure or
no,
arrhythmias, we
but
can
many things are
manage
not in our control. While
No,
intubation
no,
and
no.
stress responses are there.
Yeah.
So more than
Even
that,
with
conduct is
graded
more important
epidural,
rather
we
than
can
the
conduct.
type. Yeah.
What is
We
you
can,
are familiar and you are
Yes,
used to,
which you are
you should use that.
comfortable with
Yeah,
that.
yeah. You are comfortable. You should use
yes, sir.
that method. Yes.
Yeah, Dr.
Okay.
Amol sir, one question from my side. If I'm working in periphery and I see some STT changes, which after correction of tachycardia, hypertension, they still persist, ST depression. So, and low risk surgery is going on, say laparoscopic appendicectomy or cholecystectomy, low bleeding risk. So, is it possible, should I give an aspirin or a clopidogrel through Riles tube after doing 12 lead ECG if I'm sure about the STT changes?
You mean to say
I'm working in a
intraoperative, you
periphery.
find it
Yes.
out? Intraoperative ST depression or before operation?
No, intraoperative ST depression I
Intraoperative.
see, which I have ruled out other causes. There is no hypotension,
Okay.
tachycardia, hypertension. I take a 12 lead ECG, but still it is persist. I'm at periphery. I don't have a facility of immediate cath lab. And surgery is of short duration. I'll be extubating the patient in some time. So should I be giving any drugs through Riles tube?
Not
Yes,
necessarily.
it can be.
You can, but procedure is small, then take a 12 lead ECG postoperatively, look its hemodynamics, and you can start heparin at the most.
If
Unfractionated
the
heparin
pressure,
can be easily.
if there is no hypotension, I feel one can wait. If there is a, yes, along with those changes, hypotension is there, you have to
Yeah.
some.
So unfractionated heparin is preferred at periphery, I'm saying.
Yeah, you can
Yes.
easily reverse it also. Unfractionated heparin.
Okay.
Okay, maybe last question to Dr. Ajita madam. Ajita madam, I had a patient who was posted for appendicectomy. He was in sepsis, but by the time he got his investigations and everything, and he came within 2 hours on table, he was in atrial fibrillation, frank atrial fibrillation. So, what should I do? Should I first sedate him and shock him, and the BP was around 100/60, not actual much. The mean was around 65. So should I first treat the atrial fibrillation, or should I try to increase the BP? Should I induce or wait? Or should I give Corderon?
No, first you have to treat the atrial fibrillation because
Arrhythmia.
yeah, you have to treat arrhythmia first, rate
First.
control. If it is reverting to sinus rhythm, it is very good. If it is not reverting to sinus rhythm, at least ventricular rate should be within range. Once ventricular rate comes within range, your blood pressure will automatically improve. And then you can think of proceeding with due monitoring for the if it is an emergency surgery, or you can wait.
How much Corderon can I give?
Directly, Corderon is not necessary, madam. If you can control the rate, sometimes it see the cause, whether in sepsis there are electrolyte imbalances, hypovolemia. First treat other causes, rule out and other causes. If you want to give amiodarone, the standard dose is 300 milligram IV bolus over 20 minutes or maximum over 1 hour. But you should keep in mind amiodarone can cause little hypotension as well. So give slowly, and if it is not very malignant, it will revert soon.
Yes.
Okay, thank you so much. Over
And
to you,
every
Sheetal, madam
every
and Avinash
cardiac
sir.
patient every cardiac patient posted for non-cardiac surgery, it should be posted in hospital where ICU setup is there.
Yes, sir.
So it should be kept in mind every.
Multidisciplinary approach will be easy in good setup where all
Yes.
facilities are available for good outcome.
Avinash
And
sir,
it
with
is
your permission, can we ask the MMC observer, Jayashree madam, to say a few
Yes,
words?
yes.
Sheetal madam
Today,
and
definitely.
Avinash sir.
today we
Yes.
have
Yes.
FMC observer Dr. Jayashree Kenkre madam, who is the head of the Department of Anesthesia, Holy Spirit Hospital, Mumbai. Madam has more than 42 years of distinguished experience in anesthesia. Over to madam. Jayashree madam.
Yeah.
Hello.
Good evening, everyone. Good evening, everyone. It was an
Yes.
excellent webinar. I congratulate SAMS on this excellent webinar, and I wish you many, many more such webinars in future. As Dr. Bhosle said, he wants to have at least 12 in the year. Please
Yes.
continue the
Yes,
good
ma'am.
work. Yes.
Madam,
Thank you.
your comments,
Okay.
your
Yes.
comments on cardiac
Ye-
cases, any cardiac cases you want to say something?
Uh,
Sorry,
basic
Avinash sir.
Yeah, basically the intra cardiac output monitoring and the prediction of hypotension is the way to go today. Okay, at least in the
Yes.
urban area. The urban areas have to go into this and have to predict the hypotension because it goes a long way in the elderly to prevent the post-operative cognition dysfunction in these patients, which is a big, big issue with us in our geriatric cases. So I love that webinar, that part about the cardiac output monitoring. Thank you.
Okay. Thank you, ma'am. Thank you
Good
very
night.
much.
Good night.
Good night.
Thank you.
Yes.
Everyone, can we
We'll.
Thank you, ma'am.
Yes.
Hello.
Yes. We will.
There is one announcement, that is the certificate link will be released 3 days after this webinar. And it's my honor to propose the customary vote of thanks today. My sincere gratitude towards the chairperson, Dr. Sanjita Umbarkar madam, and Dr. Kumar Raigar sir, for accepting our invitation and present there and sharing their vast experience on this topic today. Then again, my sincere thanks to all the faculties, Dr. Ajita Anachatre, Dr. Amol Kodalikar, and Dr. Samrat Madnai, for the very good talks, and they are prepared excellently. I really appreciated their references and all the materials they have taken in their talk. And I thanks all the GCs, office bearers, all president secretaries, and more the delegates. For this enthusiastic response to this webinar, I think almost 300 people had registered for this. So
Very
thank you
nice.
very
Yes.
much. No,
Thank you.
almost
Congratulations
300.
to SAMS. Yes.
Yes. Thank you, MMC observer,
And
ma'am.
yes.
Thank you,
And
ma'am.
ISA Boruli also.
Yes,
And
to
Thank
Rajesh
you,
Jenika.
Rao and
Avinash sir.
ISA Borot.
Thank you, Sheetal madam.
Oh,
Jenika
Thank you,
also
Avinash
has
sir.
participated.
Thank
Thank you, Sheetal
Oh,
madam.
thank you, sir. Thank you for
Sir,
joining
thank
and
you,
accepting
sir,
our
everyone.
thank you,
my
thank
pleasure.
you,
invitation.
sir.
My
Thank you.
pleasure.
Yes.
Will like to
Hello.
attend every time.
सर
Yes.
फोटो विकास करने से
Yes.
Yes,
Screenshot.
everyone can just switch on the.
Please, everyone, just put on your videos, so we'll have a screenshot.
Screenshot.
Yeah, and I think Dr. Amol has to stop sharing screen. Amol sir?
Who is taking
Karne sir.
screenshot? Yeah?
I'll do it. I'll do it.
Okay. Rajesh Rao sir, namaskar. Neelam, how are you?
I'm fine, sir. Very fine. एकदम छान
Yeah.
वेबिनार 7:10ला 100 लोक जॉईन झालेले तुमच्या
Yes.
वेबिनारला
Shobha ma'am.
खूप छान.
Hello, Vikas.
Hello.
Hello.
Hello, sir.
Hello.
Everyone, on your
So very good stuff.
video.
Yeah. What is the practical difficulty we often face while making the patient fit, like either to make patient fit or unfit regarding that ejection fraction, and what to do next once the patient land up on the table, and the intraoperative events which we are to manage our own. So a very good guide for that, and
Yes,
all the speakers
your voice is interrupted. Hello.
were
Okay.
so good, like what to do in the urban as well as in the rural area. Thank you so much.
Yes, thank you, madam. Okay, Samrat, you are traveling?
Yeah, I'm there, sir. I'm there. Yeah, I am
Yes.
traveling.
Sir,
Yes.
what photo
Okay.
you have to hold?
Yes. Yeah.
He's
driving.
cardiac anesthesiologist, so yes. Okay. You are muted, Samrat.
झालं sir.
Okay.
Bye bye.
Okay, thank you.
Thank you.
Thank you. Thank you,
Thank you,
everyone.
everyone. Good night and
Thank you
excellent.
everyone.
Thank you, sir. Thank you very
Good
much.
night.
Okay. Okay.
Thank you, Lalit
Sir,
Kumar sir.
recording कसं
Thank you,
बंद
Sunita
Thank
करायचं?
you,
ma'am.
everybody.
Thank you for
Recording